Thank you very much for the opportunity to speak with you and to close out the year's series of Grand Rounds. It's a pleasure to speak with colleagues, and I am extremely happy to be in Seattle now, to be heading up the Blood Center, and to be part of the faculty of the University of Washington. I look forward to lots of collaborations in the future. The picture that I put on the title slide here is not just happen chance. It's certainly a pretty picture of the Space Needle on New Year's Eve, but I chose that for a reason, and this really is a time to celebrate in transfusion medicine. We have been successful in vanquishing the foes that we've been fighting for the last 2+ decades, particularly HIV and HCV. And I'm very happy to tell the public and tell my colleagues that the blood supply is safe with respect to those viruses. That doesn't mean that they cannot still be transmitted by blood, but the risk of their transmission is so minuscule now that we have been able to refocus our attention on other concerns associated with transfusion, particularly mistransfusion, patients getting the wrong units of blood, transfusion-related acute lung injury, a major cause of morbidity and mortality after transfusion, as well as bacterial contamination of blood, another form of pathogen transmission that has long been with us, but really hasn't until recently been able to attract the attention it deserves. In that same category are storage lesions in cellular blood components. We have been aware that things happen to blood cells while they are being stored. We've been aware of that since we first began storing them back in the 1940s and for platelets in the late 1960s. However, we have not really been able to define exactly what those storage lesions are or what they mean to patients. So I'll try to take you through some of the data, mostly recent data, in the next few minutes to explain where we stand, what we know, and what we don't know, to try to put together a picture about storage lesions in blood components. I will warn you up front that I will leave you with more questions than you came in with. I don't have the answers. We don't have the answers to most of these issues. But I'll first start by posing the question, what are we looking for from a blood component? What is our ultimate goal? From an analytic perspective, we want to make sure that the viability of the cells we're transfusing is maintained, because a cell that's not circulating is obviously not going to help the recipient. The function of that cell also has to be preserved, or its circulation doesn't really accomplish anything. And we want to make sure that we avoid the accumulation of any undesirable properties in the units of blood during their storage. And much of the next few minutes will be talking about some of those undesirable properties that we've been able to document that so far appear to be unavoidable. From a clinical perspective, we want to make sure that we have efficacy. That's the reason we're transfusing. There's a goal to be obtained. And to minimize any toxicity for the patient. That too just makes sense. From a logistic perspective, we want a component that's simply made in order to keep the costs as low as possible, and that's expedient in terms of it being rapidly available or generally always available. And we also want to be able to predict the clinical effects of our different components based on experimental testing. And this has proved to be a very difficult question to answer, one that I think we need more study using animal models, because the required human models are to perform these clinical trials in a human system just requires the accrual of way too many patients to be economically feasible for any kind of study. So of course there are many different cells that circulate in blood. Not all of them are available from your local blood center, although many of them are. Granulocytes pose a particular problem because of their short-lived nature. We won't be talking about storage lesions in granulocyte, but today I would like to talk about storage lesions in platelets for a few minutes and then move on to storage lesions of red cells, where a lot of controversy is currently brewing. Platelets, of course, are well known in their function to ultimately stop the leakage of blood from the vascular system through a complex multi-step process. We know that we need to have an adequate quantity of platelets, not necessarily within the normal range, but above some minimum, some number above zero, in order to prevent bleeding or to stop bleeding once it has begun. We also need some preservation of the quality or function of the platelets. We would not want to collect platelets, for example, from a donor who had an inherited deficiency of function, such as Glansman's, or an acquired deficiency, such as someone who has taken aspirin. So the drug profile of the donor is obviously also important. By the same token, we can't just decide to turn down the function of a platelet by adding something to the bag that it's stored in, because then that may have a longer lived effect once the platelet is actually transfused. And of course, we also know that we need enough red cells for platelets to function. There are several studies noting that in patients who are anemic, particularly profoundly anemic, the platelets are not pushed as far to the periphery of the blood flow as they would normally be with a normal hematocrit, and therefore they're not in contact with the arterial wall and cannot therefore recognize a rent in that wall and actually create the plug that is needed. But that's more of when to transfuse rather than what we're transfusing. Platelet function has been understood to be a very complex, multi-part activity that begins with adhesion of the platelet to a denuded portion of the endothelium, followed by the platelet recognize that it is stuck someplace that calls it into action, releasing various chemical mediators from granules within the platelets that recruit other platelets to the thrombus, and then ultimately provoking clot formation through procoagulant activity as well. This is, as I said, a multi-step process for which the platelet is primed and ready to go at a moment's notice. And what we would like to have after storage is a platelet that has not already been activated. We'd like to make sure that the whole processing and storage cycle for a platelet has left it with a low pre-activation state, but a potential high activation response. Also as important is adequate recovery and survival. If the platelet isn't circulating, it won't be able to do its job. However, what we usually end up focusing on is recovery and survival of platelets for a couple reasons. One, it's relatively easily measured in clinical trials, particularly using radiolabeled platelets into autologous transfusion into normal volunteers, but also because it has been thought for a long time, as Dr. Gary Moroff stated a number of years ago, that a circulating platelet is a functional platelet. And that is that as long as the platelet can be seen to circulate, it's probably going to do its job. And I'll show you some data later on that documents that he's probably right about that. Almost every step of the platelet's adhesion and activation has been shown to be affected by its storage. The storage lesions that have accumulated in the literature, let alone in the platelets, account for a long list of changes, as you can see here. I'm not going to read through them because it really is phenomenal. Everything that can happen to a platelet does happen during storage, and none of this is good. We would prefer to have none of these things happening because presumably all of these changes are in some way diminishing the platelet's ability to respond. These changes represent activation that occurs during storage because of the artificial environment, or possibly even to the agitation that occurs as the platelet bag is moving back and forth in the rotator, which is needed in order to ensure adequate oxygen exchange across the plastic surface. But nevertheless, that too has negative effects. So everything that's happening in storage is probably not something that a megakaryocyte would like to see happen to its children. How do we measure all of this? Well, there are different ways to measure individual changes in the platelet structure and the platelet biochemical milieu inside of it. But the traditional way is looking at function, and that usually amounts to some type of aggregometry. This is what is commonly applied is a takeoff of the patient aggregometry that is done to assess inherent defects, for example, in a patient's platelets. And this has been codified for those doing platelet research now as an extent of shape change reaction that is exposure of a platelet to a standard agonist, standard concentration. And one can see the difference in response between fresh and stored platelets, and the stored platelet response is usually expressed as a percent of the fresh, and of course it's always less than 100%, and that is assumed not to be good. Now there are newer and I think more physiologic means of assessing platelet function that have recently been applied to stored platelets. For example, passing a platelet suspension through a flow chamber and looking at the size and number of the aggregates that are formed. representing more of what would happen as platelets flowed through the vascular system, or use of the PFA 100, where the blood or the platelet suspension is being passed through an orifice that has an agonist coating its surface, and the time is measured for the platelets to become activated and adherent, causing a clot, a blockage of that orifice. So again, that's a physiologic approach. There are no absolute requirements in terms of licensure of a platelet product for any of these types of in vitro assays, primarily because we don't know exactly what they mean. Again, we can measure storage changes, but it's very difficult to relate to how the patient is responding after a transfusion. So declines in the functionality of platelet through assays such as this are great for publication, but they are difficult to translate into clinical outcomes. A number of studies have looked at, for example, the decline in adherence of platelets through the storage period, and the decrease in the amount or size of aggregates that are formed in studies like this. Also, platelets are shown to have more and more expression of P-selectin on their surface. That's a marker of activation, so that's not good. We would rather not have that. But also at the same time, if the platelet is stimulated so that it is beginning its aggregation activation response through something like a thrombin receptor activator, there is less P-selectin that is expressed. So the platelet apparently has already shot its wad, so to speak, and it has a reduced response after storage. Again, we assume this is not good, but what does it really mean for the patient? Thromboelastography is used in a number of different clinical settings to assess the clotting ability of whole blood in a sample coming out of a patient. And if you take a day one platelet suspension versus a platelet suspension that has been stored until well after outdate, say on day 8, you get very different tracings. The lag time, for example, the rate at which the clot forms, the time to the peak clot, and the amplitude can all change, as well as the time to fibrinolysis. So these changes occur during storage in apparently a stepwise fashion. There's usually seen to be a decreased lag time, suggesting pre-activation of the platelets, so they are more ready than usual to do their job, which you think might be good, but then, and it's also seen as a decreased time to the peak clotting and an accelerated rate. But by the same token, then you get a shorter time to fibrinolysis. So the platelet appears to really have ramped up and be ready to go, but yet if it can't respond fully, and although the TEG does not indicate that it can't respond fully, but other assays do, then perhaps the pre-activation is not such a great idea. Some of these changes may be related to increased phosphatidylserine exposure, again to pre-activation and exposure of granular membrane to the surface. There's quite a bit of change in the proteasome of platelets as well through storage, and interestingly, increased expression of cytokines, which occurs apparently through synthesis during the storage period. Some of these are actually expressed in increased quantities in the supernatant. There are also protein modifications that occur at different rates during storage. And there is actually production of some proteins at an accelerated rate during storage. For example, glycoprotein 3A has RNA present to make it during storage. And the increased production of that can be seen actually at an increased rate over other proteins, which are maintained at a stable concentration during storage, such as actin. What exactly does this mean? Do we have to consider production versus degradation? That is an issue, although we know from methionine labeling that there is increased creation of GP3A. We know that the messenger RNA continues present really throughout the storage life of a platelet, throughout the normal circulating life of a platelet. It has about a 3-day half-life. This is a very stable messenger RNA. So the platelet can indeed make more of this protein. And there are other proteins that it can make as well. It's not just that one. And some of these proteins are obviously very involved in the whole clotting system. What does this all mean? And does loss of the usual regulation of production of these proteins relate to the storage lesion in some way? That's an area for future investigation if any of you would like to get involved in the field. As I said, the storage lesion can also be seen in the disappearance of platelets, the rapidity in which they disappear, and also the survival curve, what that survival curve looks like after storage. After transfusion of platelets, there is an initial fast clearance period and then a slower or delayed clearance period. And different changes in the platelets' surface affect these different parts of the curve. For example, P-selectin exposure, which, as I said, increases during storage time, causes an acceleration of the early phase. More rapid early removal has no effect, apparently, on the long-term survival or the delayed removal of platelets. On the other hand, GP1B alpha, which decreases in expression during storage, has no effect on the early part of the curve, but this decrease in expression causes an acceleration of the latter part of the curve, so a shortening of the long-term survival. What does this mean other than just the difference in recovery and survival? Does it have other effects on the platelets? Not every donor's platelets store in the same manner. And this was recently investigated by a group out of Canada where they were able to show a very close correlation between matrix metalloproteinase 2 activity in the supernatant of platelet units and the recovery of these human platelets in a rabbit model. What is this enzyme doing? And why are different levels of this present in different people? Is there a way that we can adjust that level so that all donors' platelets survive, have the highest possible recovery and survival? Interesting question. We know, for example, that the longer you store platelets, the lower the recovery and survival, or you can see this clinically from reduced corrected count increments. Now, often when looking at a group of patients, it's not possible to get a statistically significant difference in CCI after a certain number of days of storage versus another length of storage. But the trend is certainly evident that increased storage reduces recovery and survival. So it may require, in certain circumstances, more transfusions or more frequent transfusions to keep a patient above a certain platelet count. On the other hand, what does the storage changes associated with additional time have to do with the function of platelets? Does a 6 or 7 day or a 5-day-old platelet not only not have as much of a chance for recovery, but does it do as much for the recipient? Well, the answer here is that age may not matter in this case. So an interesting study now 15 years ago, which platelets were stored, reinfused autologously, and then recaptured from the patient on the basis of separation by identification of radiolabeling. And the function of those platelets was assessed. You can see right after reinfusion, the platelets had a decline in their aggregation response to different agonists. But over the next few hours or next couple days, the function of these platelets returned. So it may be that, indeed, as Dr. Moroff said a long time ago, even before this paper was published, that a circulating platelet is a functional platelet. And indeed, studies that have looked at the CCIs of patients receiving older versus younger units of platelets certainly have noticed difference in recovery, but have not noticed any difference in bleeding of these patients or the ability of the platelets to stop bleeding. So maybe function is different. Maybe all of these changes in the end don't make a difference, but it would sure be nice to know more about all of that. Let's turn our attention to red cells now, which obviously we transfuse many more of than platelets, even in a place with a large hem-onc population, such as here in Seattle. And there have been a number of different storage lesions that have been documented in red cells over the years. Very quickly, it was noted with the beginning of storage solutions in late 40s and early 50s that ATP declined during storage and DPG rapidly declined during storage. Usually what you can do in terms of changing pH or changing other metabolic parameters of the storage solution, whatever you can do to make the ATP levels higher will cause the DPG levels to disappear more rapidly, and vice versa. Currently, the only way to keep them both up appears to be storage of red cells in an anaerobic environment, which is a new technique that is still under investigation and is not yet anywhere near licensure. So at the moment, we're stuck with a situation of seeing decline in ATP and DPG. And certainly by 14 days of storage, actually probably by about 10 days of storage, DPG has declined to a level that is not measurable and no longer affects the hemoglobin-oxygen dissociation curve, and that curve has significantly shifted to the left. The ATP levels need to be maintained at about 50% of their day zero levels in order to have the red cells to be able to be recovered on transfusion. But there is not a strong correlation. There is a correlation, statistically significant, but there's not a strong correlation between ATP levels and the recovery of red cells. That's the bad news. The good news is that this is not a permanent state. As the red cell warms up, as its metabolism returns to normal physiology, both the ATP and DPG are rapidly recreated, and within 24 hours, they are back up to near physiologic levels, if not exactly where they were when they started. However, at the time of transfusion, what is being transfused? What's being transfused is a cold unit of blood with stiff red cells, we'll talk about that in a minute, that are excellent oxygen sponges. That is, they pick up oxygen in the lungs very well, but they don't offload oxygen very well at the tissues because the PO2 in tissues is usually well above the P50 of this hemoglobin without any DPG. And so what we have done in that circumstance is provide the patient's myocardium more work to push around blood that has more red cells. It's more viscous, but we haven't really helped any more oxygen be delivered to the tissues, including that myocardium. What, of course, we all like to do is be able to predict who's going to bleed tomorrow and transfuse them today, but usually we can't do that very well. What's going on inside the red cells and how the red cells interact with their environment? Clearly, nitric oxide is important. Hemoglobin is a sink for nitric oxide, and there's ongoing exchange between nitric oxide in the plasma and the hemoglobin. In cases of hypoxia, situations of hypoxia, nitric oxide can be released. This obviously has a relaxing effect on the periarteriolar smooth muscle. ATP within the red cell can also be released during hypoxia, and this ATP similarly has a relaxing effect on the smooth muscle, leading to increased flow. So these are two normal physiologic mechanisms that can be brought into play in cases of anemia. And related to our discussion earlier today in rounds, the CFTR, the cystic fibrosis regulator, is present on the surface of red cells and is thought to be the channel through which ATP release occurs. But I'm not going to go in that, and I'm not aware that's related to the storage lesions of red cells. On storage, obviously the porphyrin the iron in the porphyrin ring can undergo oxidation, and if there is not the same metabolic potential to reduce the ferric iron back to the ferrous state, the hemoglobin becomes trapped in the ferric state, and in that state it is not able to bind nitric oxide. Similarly, as the ATP levels decline during storage, there will be less ATP, or perhaps very less ATP, to be released. So there are some opportunities for the red cell storage lesion to dramatically affect the ability of red cells to perform some of their normal physiologic functions. Also, the red cell cytoskeleton undergoes significant changes during storage, particularly oxidation, which will lead to decreased deformability. How does this all come together? Well, I think ultimately leads to a question: do the tissues have enough oxygen? And to look at an oxygen supply curve, as the delivery of oxygen decreases through either decreased cardiac output or decreased oxygen content of the blood that's being pushed around, the consumption of oxygen does remain flat for a large portion of the curve because there's an excess amount of oxygen available. And of course, as less oxygen is being delivered to the tissue, the oxygen extraction ratio can increase or will increase, and the mixed venous PO2 will decrease as the tissues take more oxygen out of the blood. So that's a well-used compensatory mechanism. However, at some point, the amount of oxygen that can be extracted is exceeded, and the oxygen extraction ratio, of course, can only go up so far. The mixed venous VO2 will begin to fall dramatically, and following that, if there's not enough oxygen, will be a decline in the tissue consumption of oxygen. So that's the critical delivery point on the oxygen delivery curve, where lactate will begin to be seen to be increased in production because the tissues have to move to anaerobic state and move from a delivery independent to a delivery dependent flow. Obviously, you want to stay above that point. That's where the patient, if they aren't already in trouble, will rapidly start to move into difficulty if you're not supplying them enough oxygen to sustain life. Well, what happens with storage of red cells? Do we get to that point earlier because the red cells, after storage, after depletion of DPG, are going to hang on to oxygen, they aren't going to deliver it? In a mouse model where they were able to chemically modify red cells to supply murine red cells that were DPG enriched or DPG depleted, you can see that the DPG depleted red cells were more likely to more quickly generate lactate production by the tissues. And that the ATP in the tissues, I'm not talking about the red cells now, but the ATP in the tissues was at a lower rate because they probably were not getting as much oxygen with DPG depletion of those red cells. A nice animal model, does the same thing play out in humans? What about the effect of nitric oxide? Is that a concern as well? This got a lot of attention about a year and a half ago with a group out of Duke where they took well-known physiology of S-nitrosyl binding in hemoglobin and tried to make a story out of it. Actually, they're trying to make a company out of it, although that was kind of lost in the footnotes of the article when it was published. What they were able to document is that the nitric oxide content of red cells drops precipitously on collection. And within 3 hours, it has dropped to essentially nothing. Now, as I'll talk in a few minutes, there's an ongoing debate about what a fresh red cell is. I can guarantee you there's no way we can get red cells to a patient within 3 hours of collection. That definition of fresh isn't really going to help us move forward. The concern was, of course, that there would be less nitric oxide in these red cells for release when they're transfused into an anemic patient. There would therefore be less compensatory dilatation, and the patient would not get all of the benefits of the red cell transfusions. What these researchers were interested in, or what their company is interested in, is developing a way of renitrosylating hemoglobin in stored red cells. The idea of taking a red cell that has lost all of its SNO, putting the nitric oxide back in, charging up that red cell so that it can indeed deliver the vasodilatation that it's supposed to deliver. Well, that's a nice idea. Will it make any clinical difference? They didn't have any human data, but they did have a canine coronary artery blood flow model that they presented some data from. And they showed that at a variety of different FiO2s, there was a statistically significant effect of renitrosylation, that the renitrosylated red cells did deliver more oxygen to tissues. However, in terms of the actual size of that effect and the clinical significance, to my eye, looking at the table, there was only a clinically significant difference at an FiO2 of about 5%. I don't know many situations where we maintain patients at a 5% FiO2. That's generally frowned upon. And at anything approaching room temperature or room oxygen tension, there really wasn't any clinically significant change in the oxygen delivery. So it's not really certain, at least to my eye, whether or not this modification of red cells for the future will help us, or whether the depletion of SNO through storage has a clinically demonstrable effect. I think we're going to have to stay tuned on that one. We do know that red cells undergo a number of different surface changes during storage. These changes end up delivering many more adhesive signals, adhesive capabilities to the surface of the red cells, and some phagocytosis signals, so-called eat-me signals, that may be involved with the decline in the recovery of red cells. These red cells on storage will also bind to endothelial cells, and you can see that increases in more or less linear fashion over time. particularly if the cells are not leukocyte reduced, although at the very end of storage there's not much difference between leukocyte reduced and non-leukocyte reduced red cells. And if the endothelial cells are pre-treated with different chemokines that may be present in different pathologic situations, particularly endotoxin, you can see that the avidity of the red cells for the endothelial cells greatly increases over untreated situations. So it may be that sicker patients are more susceptible to storage lesions. The adherence of red cells does not appear to be related to their irradiation, thankfully. Patients who need irradiated red cells have enough going on with them already, and this increased adherence has been shown to be related to increased phosphatidylserine exposure on the external leaflet. The end result of these stiffer and more adhesive cells is that, at least in this hamster model, there is a dramatic reduction in microvascular flow associated with storage of red cells. In this case, a 25% exchange related to a 63% reduction in microvascular flow of stored hamster blood. However, in this model, there's even a reduction in this flow with fresh red cells. So I'm not sure whether the hamster red cells are storing differently or whether this model is not really addressing all the correct issues. I think we need to look at that further, but clearly there's more of an effect with stored red cells than fresh ones. A number of different studies have looked at mice or other rodents where a certain amount of blood is taken out and then either fresh red cells or older red cells are reinfused. For example, in this study there was a reduction in capillary flow but not in arteriolar flow, perhaps suggesting that the SNO model is not really at issue here, but it's more of the adhesiveness of the red cells or their stiffness that's important. And that reduction in deformability can be quite dramatic if you looked at it, for example, by ectocytometry. Red cells just do not want to deform. Of course, the red cells have to markedly deform because the capillary is only about half the size of the diameter of the red cell, so they have to squeeze through them. And without that ability to deform, there is the potential for blockage, thrombosis, and also early removal from circulation. There are also interactions between leukocytes and red cells, or between leukocytes and the supernatant of red cells, and that there are a number of different responses of white cells to red cells that have been stored for increasing lengths of time, and that can lead to changes in the ability of, for example, PMNs to migrate, and also their likelihood of responding in having been activated as an exposure to red cells. So this all amounts to a pro-inflammatory response that is created by storage of red cells in granulocytes. The red cell surface changes during storage also then result in changes in morphology of the red cells, particularly echinocytes or spheroechinocytes, which they can, just by virtue of their shape and lack of deformability, lead to phagocytosis in white cells. But that phagocytosis can also have a secondary effect. Phagocytosis of red cells has been shown to result in release of various chemokines from particularly monocytes. More recent phenomenon, just given a name, which is an interesting name, difficult to pronounce, I think, unless you have a lisp, is transfusion-induced facilitation of thrombin, or TRIFT. Thrombin generation is really what they're talking about here. And this is taking advantage of the fact that it is known that there are changes in the surface of the red cell that lead to the production of microvesicles. As red cells age and as they begin to form echinocytes, that is associated with a decline in the aminophospholipid translocase activity that keeps the phospholipids on the right side of the membrane, and also the accumulation of various apoptotic or ara-apoptotic signals, as they're called, within the red cell. And some of these echinocytes ultimately do bud off into the phosphatidylserine-rich microvesicles. Joe Sweeney from Rhode Island has just recently published a paper showing that if you take the supernatant from stored red cell units and add it to a thromboelastograph type model, you can show a shortening of the time to response, the R time, that is indicating additional thrombin formation or more rapid thrombin formation through the addition of this red cell supernate. and they have actually sedimented the supernatant down through ultracentrifugation and added the microvesicles. And it's the microvesicles which appear to be prompting this. And this can be seen in an amount of microvesicles in this in vitro system that's the equivalent in vivo to the amount of supernatant that comes with just 1 unit of blood. So this may be a clinically significant phenomenon. And it may also be significant not only in terms of what it does for thrombin generation, but it also may have an effect on the immune system. I know that work has been done here showing that patients who arrive in the emergency room after trauma are already in a prothrombotic state. So adding additional prothrombotic stimulus through transfusion, particularly transfusion of older units, may place them at greater risk. By the same token, that increased generation of thrombin may also lead to more thrombin being presented to dendritic cells in the regional lymph nodes, which through activation of the PAR1 receptor can lead to a systemic inflammatory response, which could explain negative effects of older red cells in patients in general or particularly trauma patients. Interestingly, this effect was not seen with all units. You know, you can see there some of the units remain in the normal range for this thromboelastograph measure, the R time, while others drop out of the normal range. They don't drop out immediately. In fact, the first data point here that are outside are at day 31, but obviously all of the pathologic changes are occurring beyond day 21, raising the question of what's an old unit. We don't really know what an old unit is. The effect, as I said, was not seen in all units and was correlated with the amount of supernatant hemoglobin. Now, as usually measured, supernatant hemoglobin includes really free hemoglobin, plasma hemoglobin, as well as microvesicular hemoglobin. But there was a correlation between that. There was also an interesting finding related to the metabolism of these red cells. And the dark bars are those units, glucose consumption in the top, that did not have this effect seen after storage. The white bars are those that did have this effect seen. And you can see there's a dramatic change in the glucose consumption between the first 3 weeks and then after the first 3 weeks, a flip, as it were, as to what's going on inside the red cells. And this does not appear to be related to lactate production. In red cell storage, you would expect glucose consumption and lactate production to be very tightly tied. So where else is the glucose going, and is it being used in alternative pathways that for the units that did not have this effect on the clotting study, somehow maintaining a more physiologic state? Interesting phenomenon. Relating all of this to immune response, a recent study looked at the effect of the reinfusion of autologous red cells. So there's no allogeneic issue here. And after storage for 5 weeks, there is an effect there as well. Can we do something about this? Could we add something to the units of red cells? One study that has not been written up except in abstract form suggests that perhaps erythropoietin, indeed, added to the red cells on storage may have an effect. Well, what does this all mean for the patient? Lots of things are going on, but does it mean anything? And there are a number of retrospective analyses that suggest that additional mortality or organ dysfunction is seen with the transfusion of older units of blood, usually displayed as something like this, more multi-organ dysfunction with transfusion of older units. Some of these analyses are very difficult to understand. For example, in this one, looking at 2 groups of patients who got units that were either over 14 days or over 21 days of age, they indicated that there was more serious infection seen, relatively speaking, in the group that got the older units. But those who got more units were the ones who got more infections as well. And they also had a higher injury severity score, despite the fact that the authors claimed that they didn't. But my math indicated that they did. So these kind of retrospective analyses are very difficult to analyze. For example, looking at red cell storage in CABG patients, it appeared that a number of key markers, even after dealing with a number of confounding variables, were more prevalent in patients who got older units of blood. On the other hand, almost exactly the same study performed in the Netherlands in a group that have done these kinds of studies many times showed absolutely no correlation between red cell storage time and mortality or ICU length of stay. What's the disparity here? Well, the only difference that I could see is that the study in the Netherlands the study in the Netherlands used leukocyte-reduced additive system red cells. The U.S. study did not use leukocyte-reduced red cells. Is that the key? Number of studies have looked at other phenomena such as risk of pneumonia, one noted that there was an increased risk of pneumonia of 1% per day of red cell storage, even after taking into account a number of different factors, potential comorbidity factors. And they asked the question, are there other factors not being accounted for that would correlate with transfusion or with transfusion storage time that are more important and that we're missing? Good question. The study that really has attracted most attention in the last year or so is the study out of the Cleveland Clinic, where they arbitrarily segregated patients into those having received less than 14-day versus more than 14-day old blood, and showing a number of different untoward outcomes of those receiving the older units, including increased mortality. There are a number of differences between these two groups. This was not a prospective study. Actually, if you look at their table, the two groups of patients are dramatically different in a number of important ways, including ABO, showing that blood is not issued randomly, and the ABO distribution of what these patients received was very different, suggesting that the group that got more group O's, which happened to be the older unit group, may have received blood that was less prothrombotic because of the decreased procoagulant level. This is the major outcome of the paper, showing that the patients who received older blood had lower survival. And it's pretty dramatically shown here. But if you read the fine print down at the bottom, they noted that these are unadjusted comparisons. So all the differences between the two groups have not been taken into account in this study. So it really could be that we're comparing apples and oranges here. And it's not surprising if you compare different patient groups, you may get different results. I think it's also important to note at the amount of red cells that were transfused. Shown here is the graph they had in the paper of the amount of red cells transfused between the two groups. It looks pretty similar. However, if you blow up the right-hand tail of that, you can see that the group that happened to get older blood got on average about a half a unit more than the group that got younger blood. Well, does that make any difference? This same group of investigators, I believe using the same database, published 2 years before this paper, the finding that the more units of red cells that are transfused in cardiac surgery, the greater the mortality. And the breakpoint in the curve was about at 7 units. So if you look at the usage of blood in the more recent paper and actually calculate out the average difference at each of those 2 points, factor in the mortality difference, you can explain away all the difference in mortality between the young group and the old group. I'm not sure this really answers all of the questions, but it certainly raises a question about is there really a difference? A very similar study to the Cleveland Clinic study, but a negative one, was published more recently. And of course, negative studies don't garner the same press. And they found no effect of storage time, or the oldest unit's age, or the number of units that were more than 30 days old when transfused, on a number of key outcomes, including mortality, with adjustment for operative risk and the volume transfused. And that's what the Cleveland Clinic study did not include, adjustment for volume transfused. So is there really a difference for cardiac surgery patients? The answer is not known. Just to illustrate the problems of these kinds of studies, I don't want to go into the details of the study, but in a group looking at the effect of transfusion in septic patients, came up with 2 different answers using retrospective data in 2 different studies using more or less the same model 4 years apart. Why would that be? It just shows that these retrospective studies are very difficult to control and to understand. One of the more recent studies looking at the age of blood in trauma suggests again that blood more than 14 days of age was associated with more negative outcomes. But this was not controlled for ABO groups or volumes, which were hugely different across the groups of patients. So does that have an effect? Looking at oxygen delivery in septic patients, it was noted back in the early 90s that the older the unit of blood, the more negative change in pH in the gut, which they were using as their marker for oxygen delivery. This was a prospective randomized study that was recently repeated in Scotland, where they looked at essentially the same parameters, looking at very fresh blood versus blood that was well-aged. They looked during the transfusion up to 5 hours thereafter and found no differences. And in fact noted that they could not find data to support the hypothesis that the adequate tissue oxygenation was not possible with older units of blood. A prospective study from San Francisco is an interesting one, where normal subjects were brought in and were bled down to a hemoglobin of 7, were brought back and bled again to a hemoglobin of 5.5, and then shortly thereafter were transfused back in a randomized fashion on 2 different times, either their freshly collected red cells or their stored red cells. And cognitive testing was performed before and after those transfusions. So these were normal individuals, but they were quite anemic when they were transfused. And there was no difference in their reaction time or the other cognitive testing that was performed when they were given fresh blood versus stored blood. So this group did not also find any difference in the storage time. This ultimately needs to be assessed in a randomized prospective trial, and the Canadians are about to begin a very large study of this. They're looking at, I believe, 3,000 patients, ICU patients and cardiac surgery patients, who will be randomized to receive blood that's less than 8 days of age versus more than 21 days of age. They were concerned in putting the protocol together whether or not they could manage patients in protocol without having violations, because they wouldn't always know that a patient was coming and would be assigned or how much blood they would need. So they performed a much smaller study, well less than 100 patients, that was focused on just could they maintain the protocol stipulations. And they found that indeed they could. But since they had also gathered all the data from these patients to pilot their different forms and data gathering mechanisms, they decided to run the data and see if there was any difference in outcome. The primary outcome measure was mortality, and they found, much to their surprise, that the group that received the fresh red cells had a higher mortality rate. Oops, that's backwards. At least it established equipoise for their study, but it really raises the question, what are we going to find when we look at this in a prospective, controlled manner? It's going to be very interesting. So I hope that I've been able to share my consternation and confusion in all this, that we know that there are multiple storage lesions that accumulate in cellular blood components. The list gets longer with each journal I receive. They're definitely there, but the question is, what's their clinical significance? And today, I don't really know. I would rather transfuse a younger unit than an older unit, but I don't know that it really makes any difference for the patient. And if it does make any difference, what can we do about it? The idea of transfusing the youngest unit first rather than the oldest unit first will quickly result in blood shortages. We just don't have enough blood to be able to do that. So we obviously need more research in this field to understand which of these storage lesions are really clinically important, and then try to address them and remove them or minimize them to the greatest extent possible. Thank you very much.
Questions for Dr. AuBuchon?
Yeah, so given that our blood supply is chronically low, supposedly, how frequently are we actually in the situation where we're transfusing whole blood?
Well, thankfully, in this part of the country, we are not usually in a critically short situation. In fact, as the economic situation in the country has deteriorated over the last several months and hospital admissions across the country have declined, although I'm not sure it's really been represented in Western Washington, but across the country there has been an increase in the relative amount of blood available, and that has caused the average age of blood transfusion to go up. I'm not aware that that's caused any change in mortality across the country, but it certainly has caused older red cells to be used. We rarely would use whole blood. In fact, there are very few times when a blood banker will say that whole blood is indicated for transfusion. The separation of blood into components occurs even before the testing is completed. So the state of the inventory really doesn't have any effect on whether we're transfusing red cells and plasma or transfusing whole blood.
I should probably know this, but the storage media for blood varies, but does it contain ATP?
All red cell storage media include adenine, which is taken up by the red cells and converted to ATP.
So how much of these experimentally demonstrated lesions do you think could be alleviated just by maintaining the ATP level in cells? And I say this because deformability studies, for instance, if you shut off adrenergic signaling in red cells, they become, or you deplete cyclic AMP or deplete ATP, they become rigid. And that's like probably what's controlling that. And then, you know, there's not that many energy sources for the red cell, and so is ATP sort of central to most of these lesions, and why can't we maintain it?
The answer is not known. We don't really know what the clinical storage lesion, if there is one, is really related to biochemically inside the red cell. There are certainly means of keeping ATP elevated. One of the best means is a rejuvenation approach, which includes adding inosine, which can be taken up by red cells and quickly causes the ATP to rise to normal or even supernormal levels. It's not routinely used because you then have to wash the red cells because you can't transfuse that solution. But although we can make red cells, therefore, that have a near normal recovery, does that really make any difference for patients? And what about all the other metabolic changes that have occurred in the red cell during the storage time? Not all of those get changed, but they haven't all been looked at either. So it's a fruitful area of research. I'm not worried about running out of questions for the rest of my career.
I have one more. So the externalization of phosphatidylserine increases adherence, and it's been described in some ways as like an evidence of apoptosis in red cells, but that's something I've only heard about in experimental circles. Is like red cell apoptosis something that's discussed in transfusion medicine? And to me, that seems like something that would not be a reversible phenomenon.
It is generally thought that echinocytosis, which is associated with those apoptotic signals accumulating in red cells, is not reversible. By the time a red cell becomes echinocytic, it's stuck. It's not going to be able to go backwards. The ability of those red cells to remain in circulation is certainly questionable, and those red cells that are the most echinocytic may be the ones that are rapidly removed and account for lack of something less than 100% recovery on transfusion. But again, how those relate to any clinically evident storage lesions, we don't know. I would rather have red cells maintain their deformability and their normal complement of phospholipids on the external leaflet.
Mark, this will be the last question.
Yeah, and a question about intraoperative blood salvage and reinfusion as it relates to this. Are those red cells more like old cells or new cells? And I can imagine scenarios where it might go in either direction because of the trauma and so on related to how it's collected versus the fact that they're pretty fresh.
One of the advantages of intraoperative salvage of red cells has always been touted that they are fresh red cells. Now they're not warm and pulsating anymore, but they certainly are freshly collected. There is some hemolysis that occurs during collection of blood from the surgical field, but most hospitals today use a washing system rather than just a collection and reinfusion system. So accumulation of free hemoglobin is not a major concern usually. So what is being transfused are freshly collected red cells, which would presumably have normal ATP and normal DPG. There are some certainly contraindications to intraoperative salvage, but in general, it's thought of as providing excellent cells.
I want to thank Dr. AuBuchon for a great lecture. Maybe we'll stick around for a few minutes.